So, good afternoon, everybody. Thank you, Felix. My name is John. As he said, I'm a paramedic team leader for South Central Ambulance Service NHS Foundation Trust down in sunny Slough. I was a participant in 150 Leaders in 2019. So you might have seen me at the 2020 session if you were there. I'm aware of quite a few years on, but I know there's some alumni around. So we're going to talk about human factors and leadership. And it's quite a nebulous topic. I don't pretend that we're going to get through the entirety of this topic in the next sort of 45 to 50 minutes, but we're going to do our best to sort of give you a good showing and give you a bit of an idea of where things are and where you can start to get stuck in as early stage leaders, by the virtue of the fact that you're even bothering to be on this webinar, sets you sort of apart from your colleagues and your peers. So I think it's a really good place to start. But we're going to look at three main areas. What is human factors? What is this subject that you decided to try and find a bit more about today? Why does it matter? Why are we even bothering? What's the point? And most importantly, what I'd really like to spend the most amount of time on is what can I or what can you do about human factors, your human factors awareness, how you can use them to your advantage, how you can use it to make your life easier, how you can use it to make jobs better, cases better, situations better, and ultimately improve patient care, because that's kind of why we've all bothered to do this. So a little bit about me. I spent 6.5 years in the Army Reserves, where I took part in a variety of different roles, spent some time in the Falklands, in Cyprus, Canada, Germany. I'm the very, very young looking one in the middle in that sort of photo there. I then left, worked in the bar trade, restaurant trade, ran some pubs and hotels. And then in 2016, decided I wanted a real challenge and started training to be a paramedic, which involved college and university. So 2019 saw the opportunity for the student leadership program. So in the middle, that's my cohort and me over there. It was an absolutely amazing opportunity. For me, for the opportunity to sort of meet and network with other people. I'm still friends with people from that cohort in 2019, and I'd like to think that that's going to be the case for you folks as well. That you're going to have these lifelong connections across the board. Intensive care nurses, occupational therapists, physiotherapists. I still count amongst some of my really good friends that I still contact. And they come to me with ideas, how can I help them as a paramedic? How can they help me as an ITU nurse or an OT or a physio? So don't sort of understate the opportunity of cross professional learning. So 2016 started training, and in that time did my 3 years bachelor's and joined the ambulance service during COVID, which was a heck of a baptism of fire starting. Alongside working in the ambulance service, I'm involved in volunteer search and rescue, working with search and rescue dogs. And I lecture at Buckinghamshire University. We've just had our first cohort graduates. And I've also got an interest in austere, remote and wilderness medicine, where I enjoy going out, getting lost and helping people that might have also got themselves lost. And that sort of brings me to about now. So I'm a team leader, and I did a bit of a Google across the sort of the NHS jobs profiles, and there's lots of roles that suggest leadership is important or managerial sort of things are important. There's very few that actually have leader in the title. You see down at the bottom, that's me in it's a marauding terrorist attack exercise, and I'm there marked out as the team leader. Now, as a leader, you're setting yourself apart anyway, which I think is a really important thing. It's an interesting place for you to be. You're setting yourself out. You're separating yourself. You're highlighting yourself. You're almost painting a target on your back to an extent. But yeah, I think to choose to call yourself a leader, you don't necessarily need the role to be allocated to you. You don't need the title. You don't need the big Velcro tab on the front of your body armor to say team leader. But yeah, here you are. Leadership is a state of mind as much as it is a role. Which leads me on to the College of Paramedics post-registration career framework. Now, as Felix said, I'm a paramedic. There's going to be things I talk about today that might be a little bit more paramedic swerved, a bit more of a paramedic slant, a bit more urgent, emergency and critical care slant that might not be 100% relevant to your paradigm. But I hope that there's some elements of it that you can definitely pull out. It doesn't matter whether your patient is in a hospital bed or in your clinic or in the community or in a inpatient psychiatric unit or on the road or on the side of the road on the pavement or something like that. There's a lot of this can be relevant and drawn across. But yeah, as I said, a lot of this is going to be, or I'm going to come from a paramedic angle because that's who I am. So the College of Paramedics have actually recognised that leadership and management is a distinct and abject part of the post-registration career option. So as you move in through the concentric circles, through the concentric rings, you see as you get more experience, as you get more qualified, as you move up the roles within your organisations, you sort of move to the middle. But I'm quite privileged. In 5 years, I've managed to hit 3 of the 4 main areas. So clinical practice, I'm still a registered paramedic in my role. And I also hold a role as a lecturer. I'm currently an associate lecturer. I finished a year on secondment on the staff at Buckinghamshire New University. And now I'm a operational team leader. So I've hit 3 of the 4. Research, I know there's going to be some research people out there that's their thing. And I take my hat off to you. It's a lot of work. It's a lot of effort. I've participated in research. That's really interesting. But actually, yeah, it's something I'm going to look into in the next few years. But it's not really for me right now. But going back to that leadership and where we sort of affect it, a paramedic is fairly unique in that we're kind of thrown out the nest like a baby sparrow when we qualify. You know, you get your sort of 6 to 8 weeks of preceptorship and support, and you do have a lot of network around you. But ultimately, when it boils down to it, it's you and your mate at the side of the road with your big yellow bus and your bag of medicine and equipment. And you've got to make the best of that situation. You've got to lead. You have got clinicians that are in the first few years of their practice, and they are in charge. They are at the roadside in charge. They are managing complex scenes potentially before the arrival of if for myself in my role now, where I would turn up and support that newly qualified paramedic. They're essentially on their own, and that role is put upon them a lot earlier than in other areas. So I think that's really relevant. I think that's why maybe paramedics are maybe more experienced or find that early leadership, and we need to get to grips with it quite early. So we look at what human factors are. Now this is taken from the Clinical Human Factors Group, which I'm going to talk a little bit about later. But human factors has been sort of narrowed into being all the things that make us different from logical, completely predictable machines, how we think and relate to other people, equipment, and our environment. Now, human factors originated in the aviation industry, initially post-World War II, as planes were becoming more complex, but then actually processes were being taken over by the planes. We had autopilot and things like that. And planes were still crashing, and incidents were still taking place. And they had to look at what was going wrong, because these planes, you know, at the time, in today's money, millions of pounds worth of equipment, but they were still having problems. Are they still crashing, or things were still going wrong? And the common factor was found to be the people behind the joystick. You can't take people out of it. Combat aircraft, you need someone to sit behind the stick and fly the thing. So actually, they needed to start drilling into the why things are happening and understanding that there's far more that separates us and makes us different, makes us interesting. But that can impact how we practice, how we fly the aircraft, how we look after our patient, how we perform a procedure that goes beyond the technical hard skill. So what human factors is trying to do is identify, address, and then mitigate errors from looking at the individual process and also the system process, and working out, on the one hand, are we trying to work out, has the system set something up that means that we're going to fail? Or are we looking at where the individual might fail because of something that's going on in them or in their interactions with other people? And then just looking back to the Clinical Human Factors Group, it really came to the forefront as an organisation and a science in and of itself post 2005. Now, some of you may be aware of the Elaine Bromley case, where a lady went into theatre for a elective treatment, elective surgery, and actually ended up dying due to what turned out to be pretty avoidable circumstances. But yeah, went in, experienced an anaphylaxis, a can't intubate, can't ventilate situation, and ultimately the patient died of a hypoxic brain injury. And her husband, Martin Bromley, was an airline pilot, and he identified in the post-action review and in the inquest that there were very skilled people in the room, very experienced people in the room, but there's a breakdown in communication, a breakdown in those human factors, a lack of flattened hierarchy, a lack of ability to challenge colleagues. And all these things were sort of bunched together and sized up as being a human factors issue. And from there, he started the clinical human factors group, and tried to pull in those ideas from the aviation industry, where they try and eliminate issues or try and mitigate issues. I apologise, mitigate issues by trying to give as much awareness to oneself, to the other, to the team, rather than just assuming that it's because you're a bad pilot. Human factors is not, though, and it's very important that we sort of look at this, and I've already made that error as I said it, but does not look to eliminate human error. We are human. We are imperfect. We are stressed. We are tired. There's many things that might happen that cause us to not act perfectly. Situations change. But what we're looking to do is trying to mitigate rather than eliminate it, because we never aim to eliminate. It aims to be restorative, it aims to be productive, it aims to have a just and learning culture to it, where we try and give people a positive inflection to the investigation, rather than it being a, why did you do this wrong? It's how can we maybe make you do this better next time or avoid this from happening in future. We're actually trying to remove the focus on the individual themselves in the middle of a situation. It doesn't matter if it's a paramedic of 5 years, 50 years, it doesn't matter if you've never stepped foot on an ambulance, it doesn't matter if it's your first day on a ward or in the community. And a mistake's been made or there's factors to consider. It should be looking at an individual, sort of a hypothetical individual in a situation, rather than worrying too much about punishing or identifying that person himself. And also, quite importantly, it's not a limited set of principles that I can teach you during a brief training of an hour. This is something that I really hope that you folks will look into and will investigate and research and take forward into your practice, because this has got to be beneficial for you, your colleagues, and as I said, your patients. That's why we're here. And I sort of rounded it off. Human factors is not just common sense. I talk to colleagues sometimes, or when I've talked at university, I've talked to other sort of sectors, and you start talking about it, and they go, "Well, it's just common sense. Just be better. Just don't be tired." And it's just not possible. And we know that it's not possible to rely on common sense. Otherwise, we wouldn't be having these problems. So why does it matter? Patient-centered care. I think ultimately that is why we're here. Patient. I know that certain professional bodies in this webinar might refer to the people they work with as service users or individuals or something like that. But for the minute, forgive me for using patient as the sort of the catch-all term for everybody. But patient-centered care, identifying that there is ultimately a patient in the middle of a situation, whether it is in a therapy session, whether it is in an inpatient psychiatric unit, whether it is in the community, whether it's at the roadside, whether it's in the resus room in the hospital. The patient has to come first. And if you're not having the patient in the middle of what you're doing, why are we even here? Why are we bothering turning up? Why are we bothering training for 3 years, joining the NHS while it's on its knees for not a lot of money if you're not going to be working for your patient? And if that's difficult to hear, then I'm really sorry, but I think it's really important for us to remember why we turn up. Human factors and ergonomics sit alongside the hard and technical skills. So you can't mitigate bad technical skills, bad clinical skills, if you lack the human factors and the soft skills. They're pointless without each other. And ultimately, we need to know about human factors because they interact with us on a daily basis, because no two patients are the same. It's like a deck of cards that you shuffle. Every time you deal a shuffled deck of cards, you're going to get a new combination. There's a new combination of injuries, comorbidities, medication that the patient's taking, the circumstances, the emotions on scene, the emotions of yourself that you're carrying. You don't know how you're coming into a situation, the setting that you're going into, you're projecting, your bias, all these things, the patient's families, and yourself. And it matters because, as I said, you've set yourself out as early career leaders, whether you're on the 150 Leaders Programme or not. You set yourself out because you've bothered to join this webinar. You're bothering to pursue CPD as a student, healthcare professional in what you're doing, or social worker, whatever sort of background you've come from. And this is early year career leadership. It's really important that you get this done well early, and you can start modelling this to your colleagues. There's no reason that you can't mentor upwardly and be a good model and good demonstrator to your mentor when you're working with them of good examples of human factors and ergonomics. That actually doesn't need to wait until you're qualified. You don't need to wait till you're in a role that causes you to be in a leadership for you to then start thinking about human factors. This can be from day one, week one, from you starting on the road, from you starting in your clinic, from you starting in your hospital placement. So I wonder if some of you have seen the human factors Swiss cheese model. I think it's quite fun. I think it's ironic because I'm lactose intolerant that I've chosen a cheese model, but here we go. So we identify that errors very rarely happen because of one failure. And they exist in the system due to two sort of main factors, either an active failure or a latent condition. So an active failure being something that has happened there and then and in the moment. Either a slip, a lapse, a mistake, a procedural violation, somebody's gone sort of out their way, someone's done something different, or a latent condition. So, for example, existing within that system, whether there's a gap, whether they've realised that whether there's an issue that's come about due to design, due to structural issues, due to undermanning, understaffing, due to features built into the building. For example, the best example I can come up with at the moment is we're investigating a process by which a oxygen line was actually attached to suction. So patients requiring oxygen was actually having air sucked out of them. And that was potentially identified because the suction and the oxygen port were too close together and not clearly marked in that unit that they were there. But so those all there, and then you look at it that the clinician that attached it was tired, and it was the last shift of the run, and they'd done an overtime. So we start to pile those together. So we call it the Swiss cheese because actually it doesn't need to be. Hopefully, these different layers of Swiss cheese would ordinarily stop an error from happening. So as I said, starting at the top, you've got the culture and leadership, and then the technical support that runs after it, training and awareness. And then clinical support. As you get down to the end of it, all that needs to happen is those holes line up, and an error can happen. And we're trying to seek to identify where we can either realign or block those holes up as best as we can. It's impossible to block those holes. As I said, we can't eliminate the errors. We are always going to have errors, but we definitely need to do our best to try and identify where we can mitigate them. So what can you do about it? I think this is what I want to be the main nuts and bolts of the talk. I want you to start thinking about how can you influence it, how can you affect it, and how can you do better? And there's nothing necessarily wrong with what you're doing, but I think we all strive for better. So I think I'm going to start with closed loop communications and how you communicate and tone, etc., that you come into a room. And if I was to walk into a situation and go, out my way, I'm the team leader, you listen to me, you do as I'm saying, I'm not going to get any response. If I walk into a room and say, someone do this for me, I'm not going to get a response. And it's about tone and how I enter. If I enter a situation, for example, if I enter a cardiac arrest today and I say, hi folks, my name's John, I'm the team leader, what do you need? I'm going in and actually going in on a level with them that they're not they're not being shouted at. You're identifying yourself and you're starting from a good footing that we're there to work alongside them. And we talk about closed loop communication. So if I turn up on scene and I identify that things might need doing, I'm going to try and make sure that I do two things: use closed loop communication and use a name. Get a confirmation and a report back. So, for example, walk into a room and say, can somebody put an IV in that patient? Everyone else is going to think that the other person is doing it. If I say, Felix, when we get in this room, I want you to pop an IV on, and then when you've done that, can you come back and let me know you've done it? I'm going to give you another job. It's far more likely to get done by Felix, and it's far more likely that things can flow on at the same time, and it was not going to find two people trying to do the same task at the same time. It sounds simple. It kind of is. But actually, in those very stressful situations, things go out the window. Your brain just sort of disappears, and we'll talk a little bit about bandwidth later. The other thing that I think is really important around this communication is use of names. Now, I don't know about you, but during my time as a student, I was referred to the student or him. Now I'm called John. It's not that hard to remember. It's a pretty common name, but I'd still not get my name. And I dread to think how people that don't have either English sounding or English pronounced names get on, or in situations where students are changing over quite regularly. But I think there's nothing wrong with insisting that you get called by your name. I think that's quite important, and taking the time to make sure that you know each other's names. Down here on the right is the Kate Granger badge. My name is. Now, Kate Granger was a doctor that was undergoing medical treatment, and an individual, a clinician went in to tell her that she had cancer and didn't introduce themselves, didn't ask her name, kind of walked in and said, yeah, you got cancer, and walked out. And she had no idea who that person was. Dropped the bomb on probably one of the most important bits of information anyone's ever going to receive, and just walked in and walked out. So use of names is so, so important. And it's going to pull your person back into the room. It's going to mean that if you're turning up and supporting somebody and they've lost their head a bit and you can use their name, it might pull them back into the situation. It makes it more personal. It means that you're avoiding confusion, two people trying to get stuck in at the same time. Authenticity and self-awareness. Now, I have 5 years experience in the ambulance service. That's a reasonable amount of time. In other areas, in other situations, I'd be very junior in my career. In other situations, I'd be one of the most senior around and about. But authenticity, that I know myself, I know who I am, I know that what I can do, I know what I can't do. And I need to be able to identify when I can and can't do something, or what's my skill when I've had them maxed out, and having some humility about it. And that then links entirely into clinical credibility and humility. Your clinical credibility is really important. I don't need you to be the best at what you're doing. You don't need to be the best at what you're doing in the situation. If there's somebody better in that room to do it, let them do it, or support them in doing it, or even allow your learner or your student that's working with you to do that procedure, do that interview, do that technique under your supervision, and then they will learn. And having that humility to recognize when this is either out your skill set, out your scope of practice, or something that you're not comfortable doing. Because ultimately, we don't want to be stepping outside of our guidelines, stepping outside of our our ways of doing things. But your clinical credibility is really, really important. If you're respected by your peers, if you're respected by the team that you're leading, by the team that you're supporting, by your colleagues, you're going to get on a lot better. And I think being able to hold your hands up and say, this is too much for me, is really important. And I think you'd be far more respected for admitting that you've been maxed out, admitting that you've hit your ceiling of skills, rather than trying to do something and it going wrong. And in the long term, that's a loss of respect. That's a loss of, that's acting outside of your scope of practice, which is ultimately sort of then getting into fitness to practice issues. But I think humility is really important, and will be recognised a lot more than you trying to fudge it all off. So your bandwidth awareness is really, really, really important. And bandwidth is fluctuating. Bandwidth is different for different people, different for different situations. But I'm going to give the best example I can have is you must have all had times when you've driven home from a placement shift, from university, or driven home to your parents, or driven home from somewhere, and you'll get to the other side and you'll think, how did I get home? I don't remember this. I've just done 20 minutes on the motorway and I don't remember any of those junctions. I've just ended up outside my mum's house. That is an automatic process. If you're driving to a new place, you'll probably turn the radio down and you'll be focusing on the sat nav a lot more, and you'll be trying to focus on what's going on, and you'll slow down when you come into places. Junctions you might approach a bit slower because you're not sure exactly phases of lights, or you're not sure exactly how to negotiate a funny turning. And that's the best way that I can sort of separate them out. And then it can boil down to the same on a clinical procedure. So, for example, the difference between either gaining difficult IV access, difficult airway access and airway management versus in a normal, more standard situation. The one that I often think of is going and managing a paediatric critical emergency is going to be very different for me than dealing with an adult. I probably deal with 95% adult critical emergencies and 5% paediatric. So they come up far, far less. And they tend to be a lot more technically difficulties with airways, difficulties with small veins and things like that. So I'm definitely going to be slowing down and making sure I've sort of thought about it before I go in. One of the best ways, especially on these highly technical skills, is to use checklists, flowcharts, and guidelines. And I know that in my practice, our Bible is the JR Calc clinical practice guidelines, but also local guidelines, and I'm sure that they exist elsewhere. I've got some here, the RCUK and the JICAP guidelines for some very rare situations that you're not going to be dealing with every single day. So on the left, we have the shoulder dystocia for our midwife colleagues and for those that work in neonates and the obs and gynae units. A shoulder dystocia is an emergency, but is also something that's fairly commonly experienced. For a paramedic, we don't go to them that often. We don't go to deliveries that often, let alone a complication such as a shoulder dystocia. So I have available to me a reference card, a quick reference card that either sits on my phone or is actually printed as a laminate in this case, and I'm able to refer to it, that will take me through all these different processes. And I think it's really useful that in that moment, I've got either I will hold it and read it, or my crewmate will hold it and read it through with me, and we will just go through it step by step, because it's far better for me to fall back on what I know. We have the adult tachycardia, very rare, but can be life-threatening, and runs you through it. You follow the arrows. It's nice and easy. You've all seen the RCUK basic life support, advanced life support, I'm sure, of how we do it, and you just follow those steps. If you follow those steps, you can't go far wrong. And then the one that I really like, there's a feature on this one I particularly like, on the newborn life support. If you look over on the right, it says, if you tilt your head, it says, at all times, ask, is help needed? I don't know about you, but having been involved in the resuscitation of newborns or the transition of newborns to life, it's a pretty terrifying job. They're very rare, but they're pretty full on. And if we think about all those human factors that are going on at the same time, those considerations, stress, emotion, this is a baby, they're probably not had the mother's been laboring, you've got family in the room, you might be in the middle of nowhere, you might be in the dark, you might be back in an ambulance, you might be in their home, and now you have a flat grey baby that's not breathing, and you're now presented with this to deal with and manage. So you get your reference card out. But down that side, as I said, it says, at all times, ask, is help needed? Now, this is useful in hospital as well, that you're not stuck on your own. But I try and have that at the side of a couple of other algorithms that I use now when I work. At all times, is help needed? It's it's kind of almost that click, back in the room, have a quick look there, do you need any help? Rather than boshing along or assuming that you're on your own, actually, do I need help? And it just remind you that help is available. And then going with bandwidth and going with what sits in your brain, you only have a finite amount of bandwidth. So one of the ways that you can manage your bandwidth is clearing things out before the job. And there's an acronym that I want you to make notes of, and we call it HALT. You can add an L or take an L out. But before you start a shift, or before you go into a job, or before you go into a clinic, or any interaction in the community or in your unit, I want you to halt and ask yourself, am I hungry? Am I angry? Am I lonely? Am I late? Am I tired? Now, you can't always, as I said, you can't always eliminate these, but there are options potentially for you to mitigate them. Some of them are really easy. Paramedics, if you ever see us out and about and you need a snack, if you ever find yourself in town and you need something to eat and you see an ambulance, go and ask them, because they've probably got a snack on board. But go and ask. But make sure that you've fed yourself. So you can mitigate hungry by getting something inside you. It doesn't need to be a lot, but get some fast-acting glucose inside you, a couple of jelly babies, or have a biscuit or something like that, and hydrate as well. Are you angry? Now, it's quite a difficult one to mitigate in the initial term, but maybe as you're turning up to shift. But if you just had that phone call on the way to shift, on the way to your place, on the way to university, that's really riled you up, you've rowed with your partner, you've rowed with your mum, rowed with one of your friends or something like that. Actually, you need to clear that out, because you don't want to be taking that into your situation that you're next into. Are you lonely? Which kind of sits hand in hand with angry, but are you lonely? Can you do something about it? Have you had a bit of a rough run recently? You feel a bit isolated? If you've got your good friend that you can reach out to, maybe it's worth just sending that text in the morning. I'm having a bit of a rubbish one, I'm finding it difficult, but actually sending that text or making that phone call and saying, can we talk, or can we make plans to hang out next week? Something like that. So then you're trying to action that. Because lonely people are scared people, and lonely people find it, you need to give everything to your patient. Are you late? Now, lateness is just part of our human existence. As much as we sort of encourage our students, we encourage our colleagues to arrive 15 minutes early, it's just not always possible. I was late to work today because I came across an RTC on the way into work. Can't help it. But actually, I try and encourage my colleagues when they arrive late that they can't be any less late. So we encourage them to go and have that cup of tea, have a breather, reset, recenter, and then be in a position to start. The last thing that I want them to do is to run into the room as they're late, flustered, forget something, not pick up their camera before they go out on shift, not, forget to sign their drugs out, forget all these bits and pieces, when actually had they had that 5 minutes, so they're not late, they're no longer late in the building, and reset and recenter as they would normally, is really, really important. And the last one is tired. Now, again, there's not a tremendous amount you can do about tired in the moment. If you can tolerate it, have yourself some coffee, have yourself a carbonated, sugary, sugar-free soft drink that's got a bit of caffeine in it. Get some fresh air, something like that, but make sure that you're in a position to go into the room. But the other thing is tell your mentor, tell your supervisor, tell your colleagues, I'm a bit tired actually. Would you mind taking the lead on this one? I'm going to need some help on this one. So if I'm a bit slow or something, help me out, and communicate. All 5 of those can be mitigated if you communicate them with your colleague, communicate them with your mentor, communicate them with your crewmate, whoever's sort of working alongside. It's really, really important. And the other part of bandwidth is offloading where you can. So anything that you can do. So if you walk into a situation, a scenario, I'll give, for example, when we go to a cardiac arrest as a paramedic crew, we'll turn up. The first crew will commence basic life support. The second crew will turn up and we'll begin to commence advanced life support and start to get a bit of a story if there's a spare person. If there's a third crew turn up or a team leader turns up, my role is to sort of gather the situation, start to take, for example, take timings off people, trying to allow them to focus on the hard skills, and I'll start making sure that things are being done around them, or I'll communicate with the family. And it means that you are able to focus on those very specific, very difficult skills and not have too much taken over by thinking either erroneous or unnecessary in the moment things. And offload it, and actually vocalize, say, can somebody do this for me? But actually not somebody, can Felix, can you take this over? Felix, can you go and talk to the family, rather than shouting it out into the room or hoping or finding yourself drowning. So we talk about flat hierarchy. This was one of the things that was identified in the Elaine Bromley cases, that there was not a flat hierarchy. There was nurses, operating department practitioners, and anaesthetists, and all sorts of other sort of auxiliary workers in the room. But nobody felt that they could challenge the anaesthetist that was running the intubation attempts. And that's dangerous. We need an opportunity. We need to feel confident and comfortable that we'd be able to speak up and speak out if there's a situation going wrong. But we'll talk a little bit about graded assertiveness in a moment. Within that, there does need to be a clearly identifiable leader. Now, where I work, we're still wearing rank badges, so you'll see that I wear 3 pips. And where I work, if a paramedic sees me with 3 pips, they know that I'm a team leader, they know I hold a certain skill set, they know I'm a paramedic, X, Y, and Z. And I'm a clearly identifiable leader. But actually, I'm still challengeable. I'm still able to be queried, and we work on that flat gradient. We use first name terms here. We don't do any sirs and mams. We are all first name terms, and it allows for a far safer environment for everyone to work in, that no one feels too nervous to approach. In situations, everybody's included in collaborative decision making. We will include students, we include community first responders, we include our non-clinical support workers, we include everybody that's on scene, because they might have seen something that I haven't, or they might have seen something or know something or gleaned that information from going towards the family. So it's really important that everyone is able to feel on a level playing field, and they don't feel that they have to be nervous to speak up. And are we able to be challenged? Now, this one sits quite heavy and quite hard on me. I need to be able to be challenged. And if somebody feels that they can't challenge me, that fault lies with me. That fault lies with me as a leader, that I've created a culture that somebody is worried that they're going to get a bad response if they challenge me. I need to allow them to feel that they can openly, sensibly and appropriately, but they are able to challenge me in the name of patient safety, in the name of safe working. But they need to be able to challenge me. And if I don't, I've failed. If someone feels scared of me, then I have failed. And that's something that I want you to really think about, is how approachable are you? How free do you think it would be for someone to come and talk to you? So we'll talk about graded assertiveness. Now, this is really important. This came back to the Bromley case again. But how do you actually speak up? Because it's no good every time you think something is wrong to go shouting, stop, 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 when actually We just need to sort of raise that there's a bit of a concern. So there's two acronyms. You can choose either of them. They both work very effectively. So we have CUS and PACE. So CUS is concerned, uncomfortable, and stop. So if you see something happening that you're not sure about, it's not causing anyone any immediate harm, but you think there could be a slightly better way of doing it, or you think that there might be a way that you could improve that, as I said, without any immediate harm coming to a patient, you might say, I'm concerned that we might actually want to do something differently. So for example, that you think that maybe the oxygen flow level might be a little bit low. They're still getting oxygen, but actually I'm concerned that their flow rate isn't high enough, or I'm concerned that the patient's SATs are dropping, or I'm concerned that the blood pressure isn't responding to the treatment that we've given. You say I'm concerned. If there's something going on that you think really we do need to do something about fairly shortly, you might say I'm uncomfortable. So actually, I'm uncomfortable about this now. The saturations have not come up in the last 10 minutes. I know that they're still okay and they're clinically stable talking to me, but I'm a bit concerned. I am uncomfortable. And then ultimately, if you are concerned that something has gone so badly wrong that we need to stop, that is when you will say stop. PACE is another one, and it works in the same way. And we talk about it being graded, so it steps up. What we're going to say is probe, alert, challenge, and emergency. They're both just as effective, whichever one sort of sits happy in your brain. And the reason we want them graded is if you try and stop every situation every time with a stop, 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 and waving your hands, it's just going to get ignored. No one's going to listen to you. After a few times, it's going to be boy that cried wolf, and no one's going to listen to you. No one's going to be interested in what you have to say. If you start low, if you start gently, if you start polite, it's also going to be a lot better received by the person that might be making a mistake unconsciously, might need help, might need support. And then as you build it up, it means it might get listened to, and volume might go with that, or strength of tone might increase with that as you go along. But you probe: is this how we're doing it, or is it? Are we sure that's what we want to do? Alert: I just want to make you aware that this is going on. You challenge: I want to make sure that you are aware of what is going on, or I don't like what's going on. And then emergency is when you either need to take over. There's a variety of situations. I said this is maybe a bit more paramedic minded, critical care minded, that there are situations where emergencies might take place, but this is applicable to wards, ED units, psychiatric inpatient units, you name it. I think you could find an application to this. Share and give your mental model. I really like this one. This is a police dog in the United States. But don't surprise your partner with new techniques, and always share your mental model. Communicate outwards as well as outwards to everybody in the room. It's no good if you've got this amazing plan, either as the leader or as the junior person in the room. Your plan and your opinion is valid. For my paramedic colleagues and student paramedics, I know that there's someone from where I trained. You will find yourself in a situation as the student paramedic, and there might be 13, 14 other people, and you will feel that you are the most junior person in that room. And all the way you've got air ambulance doctors and paramedic team leaders and all these bits and pieces, but you need to share what you're thinking, because if you've seen something that we haven't seen, and it might just make our life easier. For example, a student the other week thought to just open the patio doors when we were trying to pull a patient down a set of stairs, and actually we could have gone out the patio doors at the back of the flat. And it saved us quite a lot of work and having to get the fire service out. So it's applicable whoever you are, but share your mental model. Don't surprise people with it. If you've got an idea or a plan, share it with people, because you'll get more buy-in, you'll get more people working alongside you. People will want to help, people want to work with you. And don't surprise them. Don't suddenly go and do something. Don't suddenly come up with a wild technique that you're going to drop on them and surprise them, because they're not going to be happy, or it might harm the patient. So how do we prepare for the big job? Every setting, every environment you work in has a big job. Depends on how you view it, depends on what it means to you, but every setting has a big job. So whether it's either that you're going into it, whether you're a student midwife going down for a crash section on labour ward, whether you've got a major trauma coming into your ED resus, whether you're a student paramedic driving to a major RTC, they're coming for you. These jobs are coming for you. They're not a may, or they're not an if, they're a when. So the first thing that I can encourage you is that you make no assumptions and you keep an open mind. Confirmation bias, anchoring bias are real things and can really slow things down on a job, can really impact patient care if you are so fixated and focused on what's going on. And don't diagnose before you've seen them. Keep that open mind, because things might be better, things might be far worse, but things might be better. And we say prepare for the worst, hope for the best. Don't rush. There's very, very, very little in healthcare that needs to be done immediately. There are lots of things that need to be done quite quickly and as an emergency, but definitely for your safety, for everything else, and for the patient's safety, don't rush in and start doing things. I like to take a 5-second pause on arrival as I get out my car, as I make sure that I've got my keys and I haven't locked them in there, or as I'm making sure I've got my PPE, or make sure I've got a helmet or a high vis or something like that. I take that moment, I actually make sure I'm putting my jacket on as I'm getting out of the car, and I can size a scene up, or I can look at what's going on, and I take a deep breath, because I might have been breathing a bit fast on the drive to the job. In my role, obviously, we're driving an emergency condition to get to the situation in the first place. So I'm trying to calm down and take a deep breath. And it's a conscious deep breath. Clears out some of that carbon dioxide that takes the shakes away. And it just allows me to just recenter. Ask for help early. Now, this is something very much focused for the paramedics in the room, but also think of your community situations, your community work, or even on wards, even on units. Ask for help early. I have yet to find a situation where I've regretted asking for a friend early in a job. The worst case is you stand them down. The worst case is you pull your emergency bell in your ward, you press your buzzer, and everyone comes along, and that they are annoyed that you've done it, that they're angry that you've done it, or that they won't understand why you've done it. They have all been learners in their time. They have all been students in their time. They have all been newly qualified in their time. Ask for help early. You can always stand it down, but ask that help early. Make sure you've got friends in the room to share your mental model, to share your bandwidth out with, to share that stress, to give other roles to. After I've been on scene for a few minutes, or after I've been in the middle of a situation for a few minutes, I take 10 for 10. I take 10 seconds to plan my next 10 minutes. That 10 seconds might seem really pointless, or might seem a bit frivolous or a bit of a waste. But actually, those 10 seconds to allow me to build my next 10 minutes worth of steps could be the difference in the job, could turn it from an average job to a very good outcome, could change it from a negative outcome to a very good outcome. And taking that 10 minutes, actually, as I've realised I need to start planning my extrication, can I now ask someone to go and do that? Do I need to call the police to close a road for me? And the last thing I definitely advise is only doing jobs only you can do. Now, in certain roles, in certain paradigms, there are certain technical skills that only you might be able to do. And there are lots of other people on scene. The best example I have is on a cardiac arrest. Do I need to be the one doing chest compressions? Anyone can do chest compressions, get someone else to do it. Do I need to be the one squeezing the bag valve mask? Anyone else can do that. I could be doing IV access. I could be sat at the feet trying to plan the whole job. I could be talking to the family. I could be liaising. I could be planning with another paramedic what our next steps are, and give the roles and job allocations to other people that can do that job. Trust your team. They know what they're doing. They're waiting for you to do your job. So leadership and followership, round this off. Remembering that we're working towards a common goal. I think, as we said at the beginning, if you're not doing this, if you are not working with patient benefit in mind, why are you here? Don't bother, hang it up, go home. Either that, or you need to have a long, hard look at why you're doing it. You can't always be the boss, and that's a really difficult one. Sometimes someone there knows more than you. Sometimes someone's more qualified than you. Sometimes someone's got a better relationship with the patient's family, got a better experience, a better knowledge. And sometimes you've just got to accept it. As that leader, you've got to choose. Are you going to be the lighthouse? Or are you going to be the fog? Are you going to be that beacon that's going to help guide people, support people, equip people, empower people? Or are you going to be in the background, making noise, getting in the way, slowing people down, and making it more difficult for them to do their job? And ego kills. Whatever setting you work in, ego kills. Is my ego slowing down patient care? And the last thing is going to be debriefing. Debriefing is an essential part of our human factors awareness. This is from the Edinburgh Emergency Medicine Foundation via Medic One in Scotland. They're a fantastic organisation, and they've put together this debrief tool called STOP. Summarise things that went well, opportunities to improve, and points to action and responsibilities. There's no finger pointing. There's no what did you do wrong. Actually, it's all looking inwards, privately, separately, not in public, and making sure it's done safely. I believe that debriefing is an art and a science. I believe that the ability of someone to do a good debrief is separate from any skill clinically, that you can have anybody come down and debrief. Ideally, actually, you want someone that wasn't on the job. You want someone that knows your job, but you want someone that wasn't on the job. And we talk about hot versus cold debriefs. A hot debrief in that first sort of hour is really, really important for us to get those first fiery hot emotions out and make sure that everyone's got a full understanding of what's gone on. So no one's leaving that situation feeling awful because they feel that they messed up. Because it might be that you all feel awful that you all messed up. It's because you don't have a full picture of the situation. And when you stop and talk about it, you actually begin to understand where errors might have happened or where errors didn't occur because your friends or your colleagues stepped in or you stepped in to prevent it happening for somebody else. But something really worth being aware of. And then a cold debrief. We try and run a hot debrief within the first hour of a job, and then we try and run a cold debrief within the first 7 days, if not a little bit later, depending on the nature of the incident and if we can gather people together. But the importance of being able to sit back down with those human factors in mind. Yes, there'll be situations where a cannula failed because of a technical issue, or a BVM failed because of a leaky seal, or a Zoll monitor failed, or things that didn't work perfectly, suction failed, or a surgical instrument failed, things like that. But realistically, a lot of these errors, as we've talked earlier, have come from a human error or a human issue, whether it's a breakdown in communication. And if we stop and boil it all down, did that error come about because you were shattered because you were on shift number 5, shift number 6? Did that error come about because you don't get on with the person? Did that error come about because you were so maxed out on a pediatric cardiac arrest that you lost your head? And that's fine. We need to understand how we can mitigate it and make it a bit better next time. So some further resources for you to consider is the Clinical Human Factors group. These are all links, and Felix is going to send these out in an email. But the Clinical Human Factors group, which was started by Martin Bromley, is an excellent repository, regardless of what clinical field or what background you're working from. And then below are 2 reports, one from Health Education England and the Chartered Institutes of Ergonomics and Human Factors, and the other is from a report from NHS England on human factors and clinical human factors, and look at it from there. I think it's really important for you to have that awareness. Just to summarise for you, as I said, leadership is your choice. You've chosen to, you've stepped forward, and ultimately you've separated yourselves from your colleagues by choosing to be here, choosing to set yourself out as a leader. And I think that this is something that you can really influence. You can go back to your station, you can go back to your ward, you can go back to your unit, your community team, and start to put some of these in place. Not necessarily to make people feel bad they weren't aware of them, but actually, as I said, ultimately we're here for the patient. And if you can make people's lives easier, make people's lives a bit better, then I think it's got to be worth a go. I'm going to sort of open for questions. At the bottom there is my email address. That's my work email. If you have any questions, anything you want to chat about, you want to arrange for a Teams call or a Zoom call, and we can chat through specific situations or specific circumstances, I'd be really happy to. Or send me an email. You can chew through a job or chew through a scenario. But I'd be absolutely delighted to help. And I'll pass back over to Felix to Q&A.